Good morning, everyone. My name is Winnie Stackelberg. I'm Executive Vice President of External Affairs here at the Center for American Progress. And on behalf of everyone at CAP, I want to welcome you to this very, very important conversation. We're gathered here to discuss a subject that too often goes unacknowledged in our society, and that is the devastating impact which mental health issues have upon women of color in our country. It's clear that women of color are the victims of many forms of injustice, from racial bias to economic insecurity and discrimination based on their gender. But what's not always as clear is how such injustice causes many women of color to suffer from greater levels of depression, anxiety, and chronic stress. And to make matters worse, too many women of color lack access to the screening and the treatment they need to live full and healthy lives. Now, I think it's pretty clear that I'm not a woman of color. But as a lesbian woman, I believe that I have some idea about how debilitating it can feel when our society makes you feel like you're on the outside looking in. And I also know from personal experience the stress and challenges that mental illness places on families. My sister is mentally ill, and while she refuses any contact with our family, I know that she loves us and that we love her. So while I can never fully understand the struggles that women of color experience, I can stand as a proud ally in the effort to provide every woman in America with a fair shot of living up to her full potential. It will take all of us, including grassroots activists, mental health professionals, members of the media, members of Congress, and policy experts working together to finally address this issue. And so before we get started, I'd just like to remind everyone that open enrollment is underway. You can sign up for affordable health care coverage and insurance by December 15th at healthcare.gov. And thanks to financial help, most people can find plans under $75 per month. Now I want to thank all these incredible panelists who will take the stage later in the program. And I want to encourage everyone to read two new reports that CAP's Women's Initiative are having released today on mental burdens and mood disorders that women of color face. I also want to take a moment to recognize one of our special guests for today, LaShanta Edwards, the founder and director of a Mother's Sanctuary in Chicago. LaShanta, who once endured the anguish of postpartum depression, now works tirelessly to help other mothers in her community in overcoming the illness. And we're so grateful that she could be here to share her inspiring story. But now, I have the honor of introducing our other special guest this morning, Congresswoman Robin Kelly of Illinois. Representative Kelly has dedicated her career to expanding opportunity for struggling and striving families. She's worked to create better jobs, safer streets, and stronger communities for the people she serves. And she's also acted as a staunch champion for mental health services and issues she's been passionate about since her time at Bradley University in Peoria, where she earned an undergraduate degree in psychology and a master's degree in counseling. Last year, Representative Kelly made history by helping to launch the Congressional Caucus on Black Women and Girls, the first such group exclusively devoted to ending the disparities that exist for Black women in areas such as mental health care. We're so thankful for her outstanding leadership, and we're so glad she could join us today. So please help me welcome Congresswoman Robin Kelly.
Good morning, and thank you all for being here. I'd especially like to thank Winnie for that wonderful introduction, for all of her work as Executive Vice President of American Progress. I just have to say one thing about your comments. You said it's obvious I'm not a woman of color. I just did 23andMe, you know, the DNA. You never know what you are. I got some surprises. A special thank you to LaShanta Edwards for your courage in sharing your story to help others. I'd also like to thank Jamila Taylor, Christy Gamble for their hard work in putting this wonderful report together that should move this conversation forward, and Carmen Valdez and Judith Warner for joining this conversation as well. It's truly a pleasure to be with you as we discuss an issue that's near and dear to my heart for quite a long time, almost my entire life. Before I came to Congress, which I never thought I would be in Congress, if you would have asked me as a starry-eyed, newly minted Bradley freshman what I was going to do with my life, I'd have told you I was going to be a counselor. And that's what I did, as you heard. I got a BA in psychology, a master's in counseling, and went to work as a counselor. I wanted to help people deal with issues so they could live healthy, fulfilling lives. I was the director of a crisis nursery, the associate director of the youth shelter that dealt with dysfunctional families, and then director of minority student services and a professional counselor at Bradley University. After that, my life went in a different direction that eventually led me to Congress, but I've never forgotten my background or work as a counselor. And often people hear me joke that my BA in psychology helps me more in Congress than my PhD in political science. But most of the time, it's really not a joke. It's true. As I was thinking about my remarks this morning, I kept coming back to the event title, Silence to Solutions. What a great concept. Let's bring voice and light to an all too often overlooked issue. But let's do more than that. Let's find solutions. So I want to talk about both parts of the idea, the silence and the solutions. We all know that there's too much silence and stigma around mental health in our country and in our communities, especially the African American community. For many, many reasons, people of color are significantly more likely to report psychological distress. In the African American community, people are more than 20% more likely to report distress than their white counterparts. However, higher levels of distress do not translate into higher levels of treatment. In fact, just 25% of African Americans will seek mental health care in the course of their lifetime, compared to 40% of white Americans. So what's the issue here? I see two major issues, stigma and a lack of access to care. Let's start with the easier one, access to care. We've made significant progress and cut the uninsured rate for African Americans in half, thanks to the Affordable Care Act. But since January, we've been backsliding, especially on mental health. Since Donald Trump took office, we've faced attack after attack on our ability to get health care, and sadly, it looks like we're going to have to keep fighting, so we need you guys to keep fighting too. We've successfully fought back 3 attempts to repeal the Affordable Care Act, but that hydra lives again, thanks to Senate Republicans and their anti-middle-class tax reform bill. The president's frankly immoral budget cut $200 million in mental health funding. We are not expecting anything better in future budget requests. With all of these attacks on health care and health care access, we are seeing voters go to the polls to stop them. Last week, we saw a clear statement from voters just across the Potomac and what drove people to the polls. Health care. According to the exit polls, health care was the top issue motivating 40% of Virginia voters. The second was gun violence, which is also often linked to mental health issues. We've won the support of the American people, but we still have a lot of work to do to ensure that everyone can access the care that they need. Federal apathy has forced state and local governments to pick up the slack in a time when they face massive budgetary pressures, meaning that access to care suffers even more. In my state of Illinois, we went 2 years, we didn't even have a budget. And a lot of smaller business, healthcare, social service businesses actually went out of business because they just couldn't afford to not get paid. Thankfully, there are some communities working hard to get smart. They are maximizing their investment and actually prioritizing mental health, largely through the City Strive initiative from New York City's First Lady, Shirlene McCray. To date, more than 180 cities have signed on, and we are making real progress by investing local government talents and know-how into connecting people with care, providing care, and addressing stigma. Another initiative that also helps to reduce barriers to care is technology and the emergence of telemedicine. Telemedicine offers tremendous opportunity, especially to deliver care to rural and inner city communities. And my district is urban, suburban, and rural. I have the south side of Chicago, but I'm mostly out of Chicago in suburban and rural districts. Imagine being able to talk to your mental health provider on FaceTime instead of making an appointment, getting time off work, traveling to the doctor's office, sitting in the waiting room, and then finally seeing your provider. One provider in my district, Aunt Martha's, has been using telepsychiatry services to provide care in southern rural Illinois with remarkable success. Right now, my team and I are developing legislation to support the expansion of telemedicine services. But increasing access to care will only do so much. If people are still too afraid or too ashamed to seek care, all the access to care in the world won't make much difference, so we must address the stigma. I can tell you that my personal experience with friends and family seeking mental health mirrors the national statistics. I have a lot of friends from all backgrounds, but I struggle to think of any friends who are women of color that have sought and received professional care, largely because of stigma. But why is there so much stigma, especially when so many of us face these issues? When it comes to stigma, we have two options. Number one, let it continue, allow it to push more and more people into the shadows, or number two, throw some sunshine on the issue. Stigma can't exist if we talk about mental health and our own mental health challenges. Stigma can't exist if we are open with our friends about our own struggles and allow them to be open about theirs. This is how we tackle stigma. It is not a grand policy prescription with moving pieces. It is each of us doing our own small part to make a difference, and it really does make a difference. Earlier this year, thousands joined my Facebook Live discussion entitled, "What Makes Black Girls Blue?" I'd like to read a few of the comments. I hear my current story, thank you, from DC. Appreciate being able to see this, from Boston. Awesome, my story, thank you, from Hoover, Alabama. Amen, and lots of praying hand emojis from New Jersey. And thanks for engaging in the conversation from Daytona Beach, Florida. These were women from all walks of life and all backgrounds facing the same challenges and struggles. By coming together, we created an opportunity for ourselves to face those challenges head on and walk away with the strength of a community. And it's within that community that we will find the strength to carry on, to keep fighting to improve access to care and end stigma, to keep fighting for the health care that we all deserve. Thank you again, and thanks for moving this issue forward. It is so very important. Thank you.
Thank you so much, Congresswoman. Before we hear from LaShanta, the Congresswoman has time for just a couple of questions from the audience. If people have questions, they could raise their hands, and I think we've got a microphone. And if it's a shy group, we can hold on. We can hold. There's one question over here. Fantastic. There's a microphone. Fantastic.
Good morning. God bless you. My name is Reverend Dawn Sanders, and my question would be around the legislation that you mentioned. I do a lot of advocacy work for faith-based organizations, and so I'm curious about how the faith community could support this legislation around mental health, particularly with the budget cuts. Obviously, I'm on the Hill all the time, you know, with the poverty issue, with the ACA, just kind of banging on doors like we will not stand for this in the community that I represent. However, with this budget cut being what it's going to be. That we need to fill, and I just want to be more practical about what we could do to support legislation like that.
Well, one thing, I just want to do a little commercial, so I'll try to get your card. There is a faith-based phone call, but I don't have my calendar right in front of me, but it's this Monday? It's this Monday where we're getting faith leaders to call in from all over the country. And what wasn't mentioned beside the Black women and girls, I'm also the chair of the Congressional Black Caucus Health Brain Trust, so I don't know how to say no. That's the problem. And so I'll be leading that phone call with Lita Clyburn about what the faith base can do. The bottom line is we need to hear your voices. And I mean, it's because of the public that the ACA was stopped. It was because everyone got together and was really focused and would not take no for an answer. And that we need to continue doing that. We need the, bless you, we need the, resistance, the voices. If you can't come to the Hill, you can write a letter, phone calls. They took their phones off the hook because so many people were calling. You can jam their fax machines. But whatever you can contribute, everything helps. But also, and share that with your congregation, too. The more people, the better to, build strength. So.
I have a question. Can you just talk a little bit about the Facebook Live effort and whether that's something that other members of Congress have offered for their constituents? And it sounds like you did it nationwide. What a fantastic idea.
It wasn't, it's myself, Congresswoman Yvette Clarke from New York, and Congresswoman Bonnie Watson Coleman from New Jersey. And when we put the caucus together, and it was women that called us to give us the idea. That wasn't even our idea to do it. They called me. I said, I can't do it by myself, and asked them to, join. So we do it together. And then we broke it off into parts like healthcare, women and wealth. Thought about ideas of what women would like to hear. So we decided we would do one on mental health because it is such a stigma. And we work with Shirlene McCrae from New York, and it went viral, I guess. And, we just did another one, but I did it as the Health Brain Trust on women and maternal mortality. I've learned so much myself. I didn't realize so many women die during or right after childbirth, so this is something that we've taken to make sure that people can see it all over the country. And I'm sure other members, do it too, or just like teletown hall meetings. You attract more people in that way, and it's working because, as you hear, we had people, from all over.
Great. One last question over here, and then we're going to hear from LaShanta.
Hi, my name's Sean Dace-Cheatney, and I'm Turtle Mountain, Chippewa. I do consulting work for policy for DHHS, and then also I'm an attorney for tribes. This is going to be a little messy, but it's kind of a new arena, and I think this is a space where folks would understand this issue, but that there are issues that are particular to communities of color. And in terms of counseling and addressing those issues, I feel like those issues are finally being acknowledged, that there are a particular set of issues that we all kind of we walk through every day. And that the emotions that follow from those experiences, your daily experiences, the bitterness and then the resulting anger, the anger in the home, the resulting trauma to children, et cetera, that are there the availability, what about the issue of the availability of counselors that can speak to those particular issues? Either they're culturally competent themselves, they're being a person of color, but also to find those people. So how do you find them? Because are they advertising that really? Is it an area of counseling? And what is the field of psychology doing on that, as this is an area there's a lot of people who need help specifically with these types of issues. And so what is that called? And is there a space for that now in the field of psychology?
Well, as the chair of the Health Brain Trust, that's actually one of our missions, diversifying the healthcare pipeline. And we have a symposium every April, and that's one of our themes. And we also recognize 40 under 40, mostly people of color in all aspects of the healthcare field. So we do talk about it, and we try to work with different organizations, entities to get more into the field. And actually we start from a very young age because with the STEM issue, because if you're going into medicine and all of that, then you have to have some proficiency. So we actually, believe it or not, start in 6th, 7th, and 8th grade, and then we just try to bring it forward, high school, college, and try to get more people interested. But we work with the National Minority Forum to try to get more people of color into the field. But yes, you're right, because I don't know. My husband is a doctor, and but he said he thought about psychiatry, but then he moved. He said no, I can't do it. But he's an anesthesiologist. But you're right about that. There's not. I could think of maybe 2 black psychiatrists that I know, and not even that many people in counseling.
Fantastic, and I know it's one of the issues that the panel is going to dig into in just a moment. Please join me in thanking Congresswoman Kelly.
I'm burning up.
Both of us want to welcome,
I have passed my summer, so it's not that. It's just
want to welcome LaShanta Edwards up to the stage, who's the founder and director of A Mother's Sanctuary. Please. Wonderful.
Good morning, everyone. Thank you for having me. I especially want to thank the Center for American Progress for hosting such an important conversation that I don't feel happens too often. I also want to thank Christy. Christy emailed me and asked me if I would be willing to participate. And I was like, absolutely. If I get to tell my story so everyone can hear, I am all for it. July 27th, 2007, I had my second child. Notice I said my second child and not my first child. My first child, absolutely amazing. Rainbows and sprinkles is what I called it. She was the perfect child, the perfect child. She didn't cry. She was the child that everyone wanted to babysit because she was such a good child. She was perfect. And then, July 27th, 2007, I had my first son. Oh, I had my first son. And it was a very difficult time for me. I went in for an induction. Just a little bit of backstory. I went in for induction for gestational diabetes. I was in this induction alone because my child's father was away because his mother was ill. So I birthed alone. I did all of that alone. Months went by. This wonderful baby boy cried all the time. All the time. And so I'm getting pointers from my family. Oh, he's crying because he's hungry. You need to give him cereal in his bottle. So that cereal they started talking about the cereal in his bottle at 4 weeks. 4 weeks. We all know that 4 weeks may be a little too early to start cereal in a bottle. However, I tried everything I possibly could to keep this baby happy. He was never happy. We would ride in a car, he would cry. We would stand there, he would cry. And in return, because he was crying, I was crying. And so then it became this ugly, vicious cycle of both of us crying. There was a day that I decided that I needed to go to Dollar General because it was my first child's birthday. We were celebrating a birthday party. Needed to get a few items for her birthday party, and I'm shopping in the store, all nice and happy, looking at plates and silverware, and my aunt walks into the store, and she says, "Hey, I thought you had Isaiah with you." Lady, what are you talking about? And at this rate, I was to the point of, who is Isaiah? I didn't even know who Isaiah was. For just a short moment, I had a break of reality because that day, Isaiah, for the first time in many months, was quiet and had fallen asleep in the car. And because he was quiet and had fallen asleep in the car, I left him in the car. And after a while, reality hit me. Oh my gosh, I left my child in the car, and I could remember crying and crying. And my aunt grabbed me and said, "It's okay, I'll go get him." But instead of me focusing on me needing help, the first thing I said was, please don't tell anyone. I need you to keep this secret for me. I asked my aunt today how she felt about that, and she said it was probably one of the toughest situations she had ever been put in. She did look at me that day and said, we need to get you some help. What are we going to do to get you some help? At that time, I was lucky enough to have an aunt that worked in the mental health field. We're not all that lucky. A lot of us aren't lucky to have that family member notice that there are some things that are happening. But even though she said, LaShanta, we need to get you some help, what are we going to do? I didn't initially go and get help. Because there is that stigma thing we were talking about earlier. I didn't want people to think that I was this bad mother. And the reality is, in my household, we grew up, whatever happens here stays here. And you don't discuss family matters outside of our home. That was very troublesome. I grew up that way because my mother also suffers from a mental illness. No one knew that my mother had a mental illness until she got into some trouble and it was circulating around the entire family. We kept that a secret for many, many, many years. I finally decided, okay, something has got to give. I cannot keep living like this. We are at year 1 and I'm still absolutely miserable. I am a disabled veteran, so I have health care through the VA. However, when you call to make your mental health appointment with the VA, this is my personal journey, I was transferred, and then I was transferred, and then I was transferred, and then I was hung up on accidentally, and then I was transferred. So at this point, I don't want to deal with it. I will handle this myself. So what did I do? I self-medicated. I self-medicated with alcohol. I was out every single day. You know, my friends joked and said me being in a bar was almost my part-time job because I was there every day. Remember, I have 2 children. Those children were always being taken care of someone else. And I was medicating myself, numbing myself, because I did not want to feel this way ever again. I have friends today that tell me that I was their ride or die. I was always there. I was always down for the cause. I was always happy. But they don't even realize that that time was probably the darkest time of my life. It was terrible. I eventually did receive help because I had changed cities. I had moved and took a contract position in the city of Ohio, and their VA system was a little bit better. So when I called to make my appointment, I was actually able to go in and see someone. But then that included giving me a prescription, a Prozac prescription, not necessarily following up. They did call and say, how's your new med? Oh, it's great. It's fine. Okay, we'll come back in. We need a refill. There was never any real follow-up. And if I didn't have the determination to keep going because I had to take care of these 2 children, I don't know if I would have made it today. So September 2014, notice that 7 years later, I found myself on Facebook. I scroll a lot. And what I noticed, there were 2 posts written by 2 different people that had no relation with one another that said, all of these people that are forgetting their babies in their car, I bet you they're not forgetting to file their taxes. And so while I was not making an excuse for anyone's behavior, I did find myself responding to these comments. Okay, so this is how this happened. It took me 7 years to tell my story because I was so afraid of not just what the community would think, but what my family would think. Because again, whatever stays here happens here. If it happens in his house, it stays in his house. I said, I have to do something. I had just completed my bachelor's in psychology. There's nothing really you can do with a bachelor's in psychology, y'all. Just, just letting you know. And I was like, well, what am I going to do? I know that I need to further my education. But once I started seeing those posts, I was like, okay, I know what I need to do. So I began volunteering for an organization called Postpartum Support International as the area coordinator. As the area coordinator, your job title means if any of the parents call and they're looking for resources, you have to find a resource for them and send them to that resource. However, in Houston/Spring, Texas, when the parents would call, I didn't have anywhere local to send them. There was one location that did a brown bag lunch support group. However, it was 45 minutes away from where we were located. So if any of you all suffered with mental health illness, you know, a lot of times you're not trying to drive 45 minutes to receive help. That's when I decided a mother sanctuary needed to happen. I could not find support groups. I could not find resources for these moms. I decided, all right, well, I'm going to do this. I founded a mother sanctuary in Houston, Texas in September of 2014. We currently hold support groups around the city of Houston and surrounding areas. We also do pregnancy education classes at some of the crisis center pregnancy centers. And we go over a lot of things with the moms in reference to, okay, it can happen. These are things that can happen, but you will get well if you seek help. This is something that I needed as a new parent, or a not so new parent, a parent in general. Not once was I ever asked if I had a family history of mental illness. Not one time was I talked about, did we ever talk about maternal mental health? That was never a part of the discussion. And as a matter of fact, when I had my third child, I had to bring it to my OB's attention that I had a history of postpartum depression because it never was a part of the conversation. So our goal in Houston is to make this a part of our everyday conversation. I will come to you. I will train your organization. I will see you on the corner and I will talk about maternal mental health with you on the corner if need be. One of the greatest initiatives right now, because we had a lot of moms, I don't know, I'm sure you all know that in August, the end of August, Houston had Hurricane Harvey. Like, it was probably a really, really devastating time for us, and a lot of our moms suffered, and a lot of our moms lost everything, from clothing to cars to, I just got a request for a full-size bed and a bunk bed for her children. Our organization started an initiative to raise funds and items for all of the parents throughout the city of Houston. So right now my house looks like a warehouse because it's full of diapers and wipes and food, and the country has been so amazing sending things to our area, and the moms are just so grateful and they are so thankful. And I want to thank all of you all, because I don't think you guys are thanked enough for actually wanting to sit and participate in this conversation, and it is really important for you all to be here. Thank you.
Thank you so much, LaShanta. That was wonderful. And thank you all for coming out today and for being part of this conversation, which we're so thrilled to be doing at CAP today. I'm going to quickly introduce our panelists, and I know we have a lot of ground to cover in the time that we have. So I will start with Dr. Christy Gamble, is the Director of Health Policy and Legislative Affairs at the Black Women's Health Imperative. She uses her unique experience in law, policy, and public health to advocate for policies that reduce racial health disparities and improve the overall health of marginalized communities. She previously served as the Democratic Health Counsel for the Oversight and Government Reform Committee, where she was instrumental in initiating the congressional investigation into skyrocketing prescription drug prices, and she was recently named one of Google's next-gen policy leaders. Dr. Carmen Valdez is a psychologist and an associate professor in the Department of Counseling Psychology at the University of Wisconsin-Madison School of Education. Her research focuses on the impact of family stress and sociocultural context on Latino children's academic, social, and emotional functioning. And she's conducted research on the role of the anti-immigration climate in Arizona on children's life course development, and is working now on developing community-based, family-focused interventions for Latino immigrant families experiencing stress. Dr. Jamila Taylor is a senior fellow at American Progress, where she serves as an expert on domestic and international women's health, reproductive rights, and reproductive justice. And in her 2 decades of experience in public policy and advocacy, she's worked on global women's reproductive health and as a congressional staffer specialized in health and education with very strong interests in the health and human rights of disenfranchised groups, specifically reproductive justice for women of color. And Jamila and Christy are the co-authors of a new CAP paper, which I hope you'll all pick up, Suffering in Silence, Mood Disorders Among Pregnant and Postpartum Women of Color. Welcome, everyone. And Jamila, I want to get started with you. This event that we're doing, these papers that we have now that are bringing this mental health focus to our work on women's health, women's leadership, are really a new departure for CAP. And I just hope that you could explain why we're doing it, why this is so important for your work.
Wow. Well, I'll say that, this is so important for our work because of women like LaShanta. I actually came into this issue. It was something that we had been thinking about because we're doing more around issues with maternal health. And Christy and I were actually having our daily conversations, as we usually do, just about the work and the issues. Part of why we're here is because we're so motivated by the women that tell their stories. And part of these conversations, we were talking about the fact that we rarely hear stories about women of color who have experienced postpartum depression issues. And we certainly hadn't seen women of color centered around conversations with mental health. And so that's why we decided to do this report. And we hope that it's the first of many conversations that we have about this issue, because it's really, when we pick the title Suffering in Silence, that's really true. Women of color are dealing with these issues partially because of stigma and also perceptions of strength, that we have to have it all together all the time. And we want to really dismantle that so we can ensure that women of color have the support that they need.
Why is it so important to have this focus in terms of, you've mentioned stigma, you've mentioned the stereotypes, and also talk about, and this is for any of you to talk about, the specific adverse life experiences, let's say, that can have such an important role in mental health concerns and how this plays out differently.
Yeah, so thank you for having me. And Jamila, that was a great explanation of the story. Everyone in the room, we're always hearing about maternal mortality. But what about the women who survive, right? As Black women, we're always told, you get pregnant, you're more likely to die. So seeing that type of label on pregnancy puts fear into our hearts. And for those women who are going into pregnancy, we think about the different adverse life experiences that they go through, particularly for the population that I serve as Black women. So you think about financial stressors. You look at pay inequities. Black women make 65 cents to every dollar that a white man makes. You think about relational stress. You think about poverty. You think about Black women. When it comes to Black mothers, 72% are single mothers, right? And now you think about the environment that we're dealing with now with blatant and arrogant, narcissistic racism, white supremacy, police brutality. In regard to women, Black women are more likely to experience police brutality, racial profiling. We're incarcerated at rates higher than we represent in this country. So those are the stressors that Black women have to deal with. Those are the stressors that Black women bring into their pregnancies. And those are the stressors that Black women think about on a daily basis. And that impacts not only their maternal health outcomes, but their maternal mental health outcomes.
Carmen, you look at the intersection of all of these factors in Latino immigrant communities, and I wondered if you could talk about how that plays out.
Yes, absolutely. Thank you for inviting me. I'm really excited to be part of this conversation and to see so many women and men in the room, because I think it's a conversation. We need to shift it away from depression and mental illness as being a problem for women to resolve and more a problem for society and an interpersonal problem. So one of the reasons why I'm interested in immigrant women, and particularly Latinas, is that, as someone in the audience mentioned, there are unique stressors. So many immigrants, I would say the majority of immigrants who come to this country are actually pretty resilient. And those who come are the risk takers, are the ones who are willing to sacrifice everything for the betterment of their family and their children, even if they don't have children yet. Being able to provide a better life for their children is a large motivator. And there's a health paradox that's been widely accepted. That is that recent immigrants actually have better health and better mental health than the native-born Latino population and the native-born non-Latino population in general. But what happens is over the years, over time, we see not only that these gains decrease, but they actually become worse than the native Latino and non-Latino population. And there have been some theories that say that maybe it's acculturating to different cultural norms and standards and expectations. I think a theory that I think is more feasible is this idea of segmented assimilation, and that is that individuals have an opportunity to move upward in society, others move downward in society, and others, because of the places that they're in and the circumstances and the adverse conditions of those places, are segmented into certain sectors of society. And so in the case of immigrants, minority status is heightened. And if you listen to the political rhetoric around immigration, one of the messages that is commonly sent is that women come to this country so they can have anchor babies, right? And so we blame women for coming here and not reproducing, but for producing undesirable children. And even though these children are U.S. citizens, because many of them are born in this country, there's this idea that they're not deserving to be here. And that can really take a toll not only on the children, but also on the parents who are dehumanized and villainized for bringing them. In fact, well-intended people often say, well, these children came through no fault of their own. And the subtext behind that, it's the parents' fault, right? When the reality is that any of us, under similar conditions, if we lived in extreme poverty, we would all do the same thing for our children. And so that level of discrimination, minority stress, and at the same time the experience of trauma, both pre-migration trauma that often is a motivator to leave, but also migration trauma, so that's the one that occurs during the journey, and then post-migration trauma are also factors that are very detrimental to women's health. And what you said, this notion that you just have to live with it, right? And in Spanish, the word is aguantar. We just endure. We endure because we're mothers and our focus is our children, and because also we shouldn't talk about our problems outside of the family. We just keep it in and we just focus on our family doing well and moving forward, but we get left behind.
There's a lot of research to show that racism itself is a trauma. The chronic exposure, which seems like something that's completely obvious, and what's interesting is that there's brain research to show how it operates, and I just wondered if anyone wanted to address that.
Yeah, I mean, I can start. I'm sure, my colleagues here also have contributions in terms of the racism piece. I think for me, in conversations around race, we sort of know the obvious, right? Where Christy talked about police brutality, racial profiling, and things like that. But I like to dig deeper and talk about the covert forms of racism. Those are the things that we don't really see as clearly as we see in terms of more the overt forms. So looking at things like how our policies are put together to the point where, large concentrations of people of color are left out of the equation. That's what structural racism is. And so we see that played out in terms of access to health care, really in all of our structural structures and institutions in this country. And so on the mental health side, it's playing out in terms of people of color not having access to providers in their communities. Large portions of our communities are uninsured. Also the economic implications of that. Christy talked about pay equity. All of those things are rooted in racism, but it's more of the structural side of that. And so I think when we have these conversations, we can't lose sight of those things because they're sort of hidden, so to say. And I think the political rhetoric we hear tries to keep us from seeing that, where it's like, well, this is just the policy. This is how it's written. Everybody has access to these things technically, but if we know that there are large concentrations of people of color that don't have access or cannot benefit from those policies, those institutions and structures, then it's racism.
That's key. That's key. As the policy wonk on the panel, I can go all into a couple policies that are clearly racist, but we'll be here all day. But I definitely agree with Jamila on that. What we're seeing with the policies memorializing stereotypes is real. We look at what's happening with Medicaid and what we have with the people on the Hill and our administration believing that these are individuals who are lazy and they feel as if they're entitled and they're looking for a handout. When we know that majority of the people who are on Medicaid are those who need it at the time and they're not staying on it long term, right? So now we're seeing policies that are requiring work requirements as if people on Medicaid don't work and they don't want to work. We're seeing these stereotypes of Black women having babies just to get more money. So what we're gonna do is we're gonna put time limits on your access to your benefits. This all impacts mental health because as Black women in this country, you feel as if I'm not entitled to something that everyone else has. And this country has this belief that if you give to those who are in need and who need assistance at the time, that's somehow taken away from what you deserve or what you get versus being my brother or my sister's keeper. And so we need to get out of that mentality of taking away from those who need help, particularly when it comes to this issue of mental health, which is not seen as a physical illness, and it's not seen by a lot of people. But we need to make sure that we're taking care of people mentally and physically, and giving them the help and the access to help that they deserve and that they need.
Yeah, I noticed on your website, mental health issues are on an equal footing with diabetes, breast cancer, other conditions. Has that always been true in the history of the organization, or is that something that came about more recently?
Well, that's always been true for our organization because we recognize that there is this secret, this secret that a lot of Black families are keeping, and there's this syndrome that we've all have heard about, the strong Black women syndrome. And our organization's been brought about to bring that to light and make sure that we, as Jamila said, we take away the stigma associated with mental illness and allow Black women to realize that this is the same as if you have a broken arm. So we have the strong Black women syndrome where, as we've heard on our panel today, that it's the Black woman feeling, I have to be strong, I have to take care of my family. I think many of us on the panel, including myself, I said, I will not cry. I will not show any sign of weakness to anyone, even when I'm feeling pain and I'm hurt and I need to keep on. And that's anchored a lot of times for Black women in your faith and your spirituality. God will get me through. I will pray through this. But we know that that is not enough. As a woman of faith, I know that supports me in ensuring self-care and mental health. But we need to let Black women and all women of color know that you can still have faith and still get help. So that's important for the Black Women's Health Imperative to put that message out there, to say that there's nothing wrong with saying it's okay not to be okay. I need help. I deserve this help. And so that's why we make a point to make sure that women see that diabetes and mental health is all issues that need to be resolved and people deserve to have treatment for.
I wanted to just chime in on the Black woman, a strong Black woman syndrome piece. And I know from my own experiences, and I'm sure a lot of the women in the audience here, I just want to say I love this picture that I see. All of these beautiful women of color here at CAP listening, engaging in this conversation is just awesome. So just wanted to acknowledge that. But in terms of the strong Black woman perception, I've even experienced it. I remember having a conversation with my mother about just feeling stressed and, experiencing depression myself. And she said, Black women don't have time to be depressed. And that was like pretty much the end of the conversation. And I think oftentimes, and then I proceeded to internalize that, which I think Black women often do, and got back to focusing on my responsibilities as a mom, as a policy professional, as a sister, as a daughter. And that perception is part of the reason why women are suffering in silence, as we have been talking about here today, because those perceptions are internalized and we feel like we can't seek professional help when we need it. And I love the fact that Christy also brought in faith and the church and prayer, which is important and should be a part of, I think, our processes to cope, but so should professional help when we need it.
Herman, I just want to jump in and ask you, is there an analog to the strong Black women syndrome in different Latino immigrant communities?
Absolutely, yes. And I think some of that is cultural because in one of the values of Latino culture in particular is this idea of the Virgin Mary who endured everything and sacrificed everything for her child. And this is a value that I think intergenerationally gets transmitted, where women are caretakers. They don't take care of themselves, they take care of others. And this idea that you have to be this perfect person who is always there and who meets the needs of everybody in the family is, comes from a place of strength, but also puts this pressure of, well, what is depression? And depression is something that I don't have the luxury to have or the time to have. But then I also think that the way we talk about depression contributes to that, because we tend to talk about depression as a brain disorder that affects our chemicals in our brain, and that can often feel foreign, a foreign concept, and particularly for women who are in a constant or constantly experiencing stress in their environment, and stigma and minority stress and isolation. So they see those pieces as being the cause of their depression, not something that's happening in their brain or in their body. So we need to shift the conversation so that it's more interpersonal, social, and structural, rather than simply biological. And I'm not denying the biological aspects of it. But the other piece that I think sometimes contributes to this idea of being strong is that nobody talks about mental illness, just like nobody talks about the experience of racism. And I know and I have had this experience, for example, of having had multiple miscarriages in my life. And every time I reached out to a friend to share this experience, they would say, oh, I'm really sorry, I've had several of them as well. But no one had ever shared that with me. So people feel like they have to go through that experience alone because of the shame of what it means to not be able to have a biological child, right? Like we put so much pressure on what it means to be a parent. And so I think that contributes to this notion of you just don't have the time for it, or you don't have the luxury to experience that. I wanted to also add something to the previous question about racism. And one of the ways that I see racism gets under the skin in my work with immigrants is we hear in our society and in our political rhetoric about what it means to be an immigrant. And what are some things that we hear it means to be an immigrant? Rapist, criminal, committed an illegal act. And all of these messages can become very confusing, particularly for young people. And so in my work in the Southwest, I ask adolescents who are children of immigrants, I ask them, what does it mean to be an immigrant? And some of them say, it means to be a criminal. And then I ask them, is your family immigrant? And some say yes, and some say no. But the psychological toll of seeing oneself through the eyes of others is really tragic for these youth who are hoping to be able to graduate, do something well in society, but who have internalized the idea that they're not deserving of these things, and the experience that they talk about their parents being hardworking, and at the same time, then how do you make sense of your parents being hardworking with also being a criminal?
Wondering, you have talked about the research that you've done, looking at how policy plays out, how politics play into this. In a state with very strong anti-immigrant legislation, let's say, the effect of that on the mental health of children and families. I wondered if you could talk a bit more about that.
Yes, absolutely. Something that, well, my research started in Arizona because of SB 1070 that was passed in 2010. But we are living nationally now SB 1070, in essence. And what I'm seeing a lot of is tremendous fear in the community, which has ripple effects on other aspects of life. So if you're afraid of being stopped and deported, then you're not going to report crime when you see it. You're not going to report being a victim of violence, even if it's within your own home, because you're afraid of being separated from your children or of something happening to the family. And the other piece is just this tremendous fear of what will happen to children if parents are deported. And so I host and participated in conversations in schools for parents. So right after the election and right after there was an increase in raids in many sanctuary cities, and what I heard a lot of, so my intent was to come and talk to parents about how they can have conversations with children about the immigration climate. But many parents, what they're interested in is what will happen if I'm picked up at work and my child comes home from school and there's nobody there to open the door for them. So they're at that level of trying to make a plan of what will happen to their children. And so that is heightening a sense of desperation, loneliness, helplessness, fear and anxiety, and the children are experiencing just as much as the parents are. But for them, it's very difficult because they feel helpless. As children, they feel like they have zero agency over their lives and over what happens to their parents. And then what happens when families do actually experience deportation is the separation of the family not only leads to financial stress, not only leads to food insecurity that can last for several years, but it also has the psychological impact on what's called ambiguous loss, which is the sense it's grieving the, so to speak, death of a relationship when it's not by choice. So it's not because you are divorced or you choose to end a relationship, and the other person is still alive. So it's not like when somebody dies that you grieve that that person is no longer there. In this case, it's different because the person is there, but they live in another country. And you either have the choice of moving on with your life, even though that you're still psychologically tied to that other person, or you remain connected to that person, but they're not physically in your life. And that has been one of the primary contributors to depression among women who have been separated from children or from a partner.
Christine, Jamila, I wanted to ask you, when, Christy, you brought this up before, the moment that we're in, this moment of more and more overt racism, hate crimes, white supremacists on the march. What are you seeing, hearing, reading, and research about that effect on mental health?
Wow. So, do we have enough time? Well, you know, we're seeing a lot of stress, and the research that we're doing has to do with, of course, maternal health outcomes, and we're noticing that across the board, low income all the way up to higher income Black women, we're seeing lower birth weight babies. As I mentioned before, Black women dying at a higher rate because of pregnancy-related complications. And there's been all this speculation about why we're seeing that. And people speculate it's because of a higher, or we're disproportionately more likely, or disproportionately seeing more chronic diseases, having to deal with chronic diseases such as diabetes and obesity, those health conditions that are risk factors for pregnancy-related complications. But as we say at the Black Women's Health Imperative, that's not really the case. Yes, it has a little to play with it, but it's really the stress that Black women are dealing with, and it's the stress now that we're seeing associated with racism. It's a heightened awareness of what is going on, the rhetoric, as we've all mentioned, and the covert and overt racism that Black women are having to deal with on a daily basis, and having to cope with that and internalizing that, and that harms us inside, and we're seeing less women, of course, coming for treatment, but we're seeing women cope in ways that are not really healthy for them. As LaShanta mentioned in her story, people are resorting to maybe alcohol or bad eating habits or staying in abusive relationships, because we know that Black women, more than 4 out of 10 Black women have experienced violence from an intimate partner. So we're seeing these coping mechanisms with Black women that are associated with what we're seeing now with this racism and white supremacy that's been emboldened at this time.
I think also to add to that, you know, what I think we will need to start looking at moving forward is how police violence is impacting Black communities. You know, in the past several months, I have met women who have lost their children, their sons, you know, to police violence and other forms of violence in their communities. And they had gone several months and years, you know, with post-traumatic stress, but didn't know how to recognize the symptoms, nor had they been, you know, formally looked at by a medical provider. So I think in terms of, as we think about how to broaden our work around this issue, I would love to delve deeper into that, to one, be able to hear those women's stories, and to also think through how we can look at how these mental health issues due to violence at the community level is impacting Black parents in particular.
I'm going to have to go to audience questions, but before I do, I want to ask you all one last question that I think allows us a little bit to get into policy as well. And that's the question of providers, of people who can provide support, high quality support. How available are these people? How findable? And also how diverse? I mean, we know the mental health workforce is almost entirely white. How culturally sensitive are they? How linguistically competent when necessary are they? What's the landscape? And since, I mean, we essentially know some part of the answer, what can be done about it?
Who wants to start? You know, I'll just say briefly, and, you know, we'll definitely let my colleagues chime in here. You know, there is a shortage of providers that look like us, particularly mental health providers, but I think even across the healthcare field, I mean, this is a problem. And we know that for communities of color, people of color, that we do prefer to go to the doctor and see people that look like us. So we need to do more in terms of ensuring that people of color, you know, are interested in working in these fields and that they have the resources that they need to get into supporting mental health services for communities. Cultural competency is also a big piece of that. The cultural appropriateness of the care that they are giving is also a piece. I think we also need to do more to make mental health services more affordable. You know, mental health care is something that is still largely not covered by insurance, and going in to see a counselor or a psychologist could be $200 for a 50-minute session. And so, you know, there are many people that can't afford that. And so that's also a piece of the work that we need to be doing, is making these services more affordable.
Yep, I agree. And I actually, and I'm glad Jamila mentioned that, but we also need to make sure that services are accommodating of individual schedules, right? So we know that, I'm always throwing these statistics, unfortunately. We know that a lot of women of color tend to disproportionately make up the low wage worker force. So taking time off of work to go to appointments really prevents them from getting the full range of their salary and their pay. Also, it prevents them from being protected from any type of discrimination they may be facing from their employer if their employer finds out who they're going to go see. So we need to make sure that when we do reach out and try to get more providers of color, more providers who are culturally aware and sensitive, we need to make sure that providers are accessible and having hours, evening hours, weekend hours, so that women can actually get the care that they need without having to jeopardize their work or financial status.
And what I would like to add is also that we've historically thought about cultural competence as what a provider needs to know about the groups that we work with. And that's really not the right approach, because it puts the focus on learning about the lives and stereotypes, reinforcing stereotypes about other groups, and it puts less of an emphasis on, on what we bring to the clinical encounter, and the bias, the privilege, our backgrounds, and how those affect our interactions with our clients. And so when I talk to students about this, I say the idea is not that you need to be competent, because competent means that you've reached the point where you know everything there is to know. But what you need to be is culturally humble, which is that you acknowledge what you bring and how your own experiences shape your beliefs and your practices, but also acknowledging that there are many things you don't know. So it helps me as a Latina to know some things about Latino culture, and it helps that I've lived through some of them. But it doesn't mean that my experience is everybody else's experience, even if they're from the same cultural background. So having that sense of curiosity and acknowledging that you don't know everything then allows you to explore the personal experiences, the family situations and circumstances, and to make it more of a collaborative process. But then the other piece to that is that we tend to isolate mental health from other aspects of people's lives, like education and work. And so one approach that I'm advocating for right now through my work is that we need to do a better job of bringing mental health to schools or to employment settings, because those places tend to have more people who look like us, right? And so through my interventions, for example, rather than doing them in clinics, what I'm working on right now is a collaboration with schools who have school guidance counselors and people who generally come from the community and who already have relationships with children and families, but who may not necessarily have the clinical training. And so partnering, creating community partnerships between schools, mental health clinics, so that they can work together and normalize, destigmatize mental health in these settings. So I think that's an important aspect also of increasing cultural competence.
That's great. That's a perfect place for us to stop and to take audience questions. Thank you.
I have two questions. My name is Velvet, right? And I'm a former teacher in DC, and I taught at Cesar Chavez, where the campus where I taught, almost 90% of the students are Latina or immigrants. So that's my second question. My first question is, not my first question, I appreciate the conversation happening, and my question is around, it seems like, this is my experience of the conversation, that we're missing a piece, and that I am experiencing this as if it's incumbent upon me as someone who may be experiencing some mental illness challenges, to come forward with that, to recognize that I'm in that place, and then to self-advocate. And is there any conversation around pushing this back to, I think you mentioned it, to my initial exposure in a healthcare setting, and how do we shift the paradigm so that if people, particularly women and children, are going for a health screening, how do we get the screening to open up and include some sort of mental health screening as well, instead of I'm going in for a physical and I have to say I'm experiencing these mental challenges. What can you do for me when I may not be able to recognize them in myself? That was my first question. My second question is, and then I'm going to sit down and let you answer. My second question is around schools. And you touched upon that. How do we, particularly if in immigrant populations as well as in populations of color, if mothers are experiencing mental illness, that is often projected onto children, and how do we then, there's a lot of conversation in schools around looking at education through a trauma-focused lens without a clear definition or explanation for what that means. And so we're missing the whole piece that children are coming to school living through the experiences of parents who are suffering from mental illness, and how do we address that as well?
Yes, well, to speak to the school question, I have seen some really great models of how to change school culture so that teachers, principals are more aware of the family experiences and circumstances of students. One school counselor who I know in Wisconsin, she did a project where she ran focus groups with students to talk about their daily lives. What are some of the experiences that they have after school and as part of their homes? And these children talked a lot about hearing gunshots or about hearing domestic violence disputes upstairs and the child having to call the police. So experiences like that. And they created a book illustrating, so through drawings, illustrating some of these experiences, and then brought teachers in and said, so when your child comes in and didn't complete the homework or is acting out what are some of the things that may be happening for them? And then working together on these books for teachers to better understand the experiences of children. Because teachers often go to the, why aren't they listening? Why aren't they bringing in their homework? Or why aren't their parents involved? Et cetera, et cetera. And the more empathy we can create, the more understanding we can create around mental health issues and about social, economic, and community factors, the better we can be at knowing how to have conversations and exploring, asking questions about what's happening in somebody's family or what may be happening in the community. So that, yeah.
I think that we tend to go to the 5 blatant indicators, particularly in school: hunger, domestic violence, violence in general, lack of parent engagement, or some other social issue. What we don't do is have a conversation around what happens when mom can't get out of bed and you have to dress yourself. What happens when parents are drinking a lot because they're depressed. We don't have those conversations. And so how do we shift the paradigm to those conversations and not what I deem the 5?
Yes. And I think schools sometimes feel like it's not their place to get into family issues, and that's part of the problem. And some teachers that I've spoken to say, well, I just want for everyone in my classroom to focus on education because that's what I have control over. I don't have control over family and what happens in the family or what happens with the parent, but I have control over this. But the problem is when you take that attitude is then you treat everybody the same, which sounds noble in principle, but then you miss the opportunity to support the students who are struggling and who really have parents who are struggling. So, but part of that also is that we don't ask teachers and we don't ask schools to reflect on their own experiences of racism, maternal depression, difficulties. And so a lot of teachers who have had these experiences but haven't processed them themselves can't really access the language that's needed to ask the questions or to validate the experiences of students. So we not only need to change the culture of teachers and how they believe they should be involved in their students' lives outside of the classroom, but we also need to change the culture of the organization that allows these staff to feel that they have the resources to actually help. Because a lot of staff get parents who come and share their experiences with them, but they don't know what to do and how to support them.
Just to add on to your question about how do you bring the services to you, to the person, rather than everything being on the person to go access them, especially when there's such a shortage of providers where they're, it's so expensive that it's inaccessible. There's an organization, for example, in New York called REACH, which trains pediatricians and school personnel in screening and in some very basic support services so that they're able, these are the people who are on the front lines. In this case, it's focused on children, but in terms of a model, they're on the front lines with kids in the first place, doing well child visits, et cetera, and they learn how to make the most of that time in order to be able to screen and to look for mental health issues, and then be able to do something about them beyond just referring out to a psychiatrist, let's say.
I was just gonna, you want to go talk about the ACA?
No, go ahead.
Oh, I was just gonna say, just on the integration piece, because I think that's what you were getting at, right, in terms of like the health services side. So under the Affordable Care Act, mental health screening should be integrated within these other health care services that you access. We do still have an issue in terms of the treatment for mental health care being covered and affordable, which we talked about. But mental health screening should be a part of your primary health care. And there are also public health professionals that have made recommendations about how best to implement that under the Affordable Care Act. So as we continue to do the work in the resistance and protect the ACA, we anticipate that continuing to being a part of our healthcare system. And we still have work to do. It's not perfect, but just to say that screening should definitely be a part of your healthcare experiences.
So I also wanted to get at that first question that you had, and it's great. We've made a lot of strides with the ACA, and as Jamila said, screening should be included, but it should be right. And we know that a lot of women are not getting that diagnosis, and they're not getting screened. So what happens? This is what I always say. This is when you come into play, right? Because we can talk about the policies that we're seeing federally and nationally and even state level. But this is why it's so important for women to come forward and tell their stories, and for women to be included in the conversation as stakeholders. And this is where policy change happens, right? Because you have individuals who come together and say, no, this is not what I'm finding. Although we should be getting screened and we should have access to treatment, that's not happening. And we need to make sure, and we need to demand that we're getting the services that we need. So that means individuals like you going to the individuals who make those policies, sitting down with hospitals, sitting down with provider groups like the AMA, and having this discussion on how can we ensure that women, not just do a pediatrician, but women in every single part of the healthcare system that a woman may hit, how can we ensure that she has that mental health screening? And she's not just screened in 10 minutes, because we know providers, unfortunately, are trying to pull everything into 7 to 15 minutes, having a twin sister who is a provider. So that's a burden on them, so to speak. But we need to find a way to have it be a part of that conversation. Whereas the doctor may not realize there's been a change in emotion or mood for the woman, their family members may be able to say, something's not right, something's going on. But we need to have individuals like you in the room. And this is why this is great for us to be having this conversation, to put the call out there to say, we need to have all stakeholders at the table, and not just provider and traditional policymakers at the table, but the women whose stories that we're talking about, and the people that really matter, to see some change happen.
Not just insurers.
Yeah.
Just insurers, yeah.
And
I left them off.
Also that, and something that I mentioned earlier is that we put the burden on, which you mentioned as well, we put the burden on women as, women being at higher risk of depression, and therefore they should be the ones who advocate for themselves. But male depression is just as common and largely undetected. And because we consider this to be a woman's issue, then there's also less support around it. But in my experience, some of the partners of women that I work with are just as distressed, just as depressed, and yet nobody asks them. And in part it's because the instruments we use are largely based on women's experience of depression and not on men's experience of depression. And the more we can include the family, then the burden is not so much on the woman herself, but also on the family as a whole, the partners, and then the community at large. I mean, I think as a community, if we need to take care of our citizens, our residents. If not, the community will suffer as well.
Hi, my question is about empowerment, and you guys have talked up there a lot about how sometimes the biggest obstacle can be seeking help in the first place, and how can we help our family members, our loved ones, understand that you can still be strong, you can still be independent, and you can while asking for help?
Oh, that's hard. I mean, I know for me, stress is an issue. Having a demanding job, and then I'm also a single mom. But it's interesting but I allow myself to, of course, the perceptions of strength are also always in the back of my mind, but I also allow myself to be vulnerable, even at home. And if I'm overwhelmed, I don't have a problem with saying, like, son, let's eat out for dinner instead of me cooking, or, let's, why don't I have you work on your homework alone while I have some quiet time, or what have you. And it's so interesting because, my son, I'll even catch him now being like, how are you? Are you okay? because he recognizes that. And at the same time, I also make sure that I don't put that stress onto him. But even with him just asking if I'm okay, and I'm sure you all get this too, right, where people ask if you're okay, and it's okay not to be okay. It's okay to say, I'm not okay, and I need some time to myself, whether it's in the workplace, with your family. But I encourage people to do that. And if you're not okay, to take time out to yourself. And as family members and friends, allow those people in your life to have that time. And make sure that they know that it's okay for them to not be okay and to have time to themselves. I think that is one of the most important things that you can do. Checking in on people. Don't forget to check on your strong friend. Is what I would say as well, because that's also important. Those people in our lives that we perceive to be strong and like have it all together. I've had people say that to me, and I'm kind of like, little do you know. And no one has it all together. Everyone has moments of vulnerability and weakness, and everyone needs to take a time out sometimes. And so I think that is one of the most important things that you can do, is just letting your loved ones know that it's okay to not be okay, and giving them that space to, rejuvenate is key.
A different way, I think, of also thinking about resilience is we as providers or researchers or practitioners need to acknowledge that there's a great deal of resilience in underserved communities and communities of color. We because we're so immersed in the problems, we often fall into the pattern of thinking that, wow, their lives must be so miserable or so hard. And then you step into their homes and you see baby pictures on the wall, and you see things that they've made themselves that they take, or the furniture that they have that they take so much pride in. And those are the pieces that we often miss, and that we could capitalize on more. It's just the dignity, the hope, and just the grit of keeping on and moving forward in life in spite of all of these difficulties. Yeah, so that's just a caution when we talk about this. Sometimes if we tend to think about it as such a deficit or such a pathology, and not as how people adapt and make the best out of a situation that they're in.
That's true. I will say too, I think particularly for the Black community, yes, we're here and we're talking about issues and the problems, but I know Black folks are some of the most resilient people that I know. And so whereas we have these issues, get up in the middle of the day and have a dance break, or spend time with the people you care about. Really make time for self-care, which I feel like we kind of almost overuse that term, but it's so important. And having joy in your lives is so important, even if it's something as small as like reading a book, by yourself for 30 minutes. That's another thing too. It really has to be a part of your life, building in that time, even if you have to put a reminder on your phone. To have time out to yourself, or do something fun. That's a big piece of it too.
Hi, my name is Mahogany. I work at Upward Bound at GW, and the question I have is, how do students who are children who are experiencing like having a single parent or stresses about racism, police brutality, things that parents have to teach them very early on compared to white children, how does that affect their mental health as far as growing up too fast? Because I've noticed that my students, though they might struggle in school, a lot of the life lessons or things that people learn later on as far as like how to be around the police, or noticing where you're at, or making sure you're safe, or cooking, or anything like that, they become adults in some areas, and that shifts from their education. Like, how does that work with their mental health, and what are some things that we can do on our side to kind of remind them that they're children, or remind them of other areas that they should be focusing on?
Oh, that's a tough one.
Yeah,
Yeah,
I will say, because my son, I have a son who's 12, young Black man, and so we have had to have some of these conversations. But one of the things that I refuse to do is to have him not have joy enjoy growing up. Like, I refuse to tell him not to wear hoodies. You know, because he loves to wear hoodies. He will wear them every day, sometimes the same one every day. And I've had people tell me, you know, well, you know, after Trayvon Martin, I will not allow my son to wear hoodies, and I refuse to do that. We have those difficult conversations, and I'm constantly checking in with him. He is happy, resilient, loves life. But he also knows that there are some issues that are specific to him as a young Black man that he is going to have to deal with. And so his dad and I really focus on making sure that we have those honest conversations, but also encouraging him to be joyous, letting him be a kid. You know, and I will say that it's also an issue for parents too in terms of the stress that can be associated with this. You know, you worry about, you know, your kid walking alone to the 7-Eleven or what have you, because these stories are so vivid in your mind. But I think that it has to be a strategy where we're having the honest conversations, but also making sure that our children know that they can be resilient and have joy and enjoy growing up. And that, you know, they're blessed to be young Black people, and not to let these situations discourage them. I think that's a key point. You have to have the joy, but also, you know, making sure that they're aware of their surroundings and that you're having the important conversations.
And they're growing up in a time when self-care is being thrown around so much more than when it was when we were growing up. But what I wanted to add in here was the fact that the younger population, the millennials, we're seeing such a resilience movement. And so they're seeing what's going on and they're moving forward and saying, oh, I'm not going to stand for this. I'm going to fight back. And so through that, they've gained such self-confidence that a lot of us didn't have when we were younger. And that's helped their mental health as well, because they feel like they have something to contribute, and that they have a voice in this fight. So we are seeing some type of resilience help younger people with their mental health. But unfortunately, I do believe that they are growing up much faster than they need to be, but they're doing it in such a way that we're seeing that they're actually helping in their mental health abilities.
And having these conversations too, like, we're knowledgeable, right? We know that help is out there. We should also be giving those messages to younger people, like, yes, you're resilient, you're happy. You know, at the same time, if you feel like you do need to talk to a professional, let me know. I'm happy to help facilitate that process for you. So that's another piece too.
I think oh, go ahead. We'll take the last one.
Okay, I was just going to say, I came to this country as a person without papers. My mother brought me here, so I grew up as I guess what they're calling now an illegal, undocumented person, a Black person, right? So I had all your issues. But I will say that we did whatever was necessary to avoid interacting with the institutions that have been sort of prominent in your discussions today. We did not attend a formal church. We did not go to any clinics. I don't think that at the time schools required medical health forms or anything like that, so we did not go to doctors or places where we could interact with people who would say, oh, you might need mental health. We did, however, go to hair salons. We were part of a SUSU, which is a community money sharing group. And I'm wondering if, besides the traditional ways that you all have focused on the clinics, are there any sort of radical alternatives to reaching people where you're training everyday people, that immigrants like myself or that the people would run into in their daily lives without having to worry about being reported to the INS or being stigmatized? Is there money being poured into things like, there's a woman in DC, Shauna Renee, who has a great storytelling initiative where she's getting women together to sit and tell stories as a way of healing themselves and others. Are there ways for groups like that to get more focus in your discussion?
Did you do any of that in your initiatives?
In what I'm thinking of is in schools, is one of my dreams would be to create a curriculum, and I've actually been in conversation in the school in Phoenix to do this, to create a storytelling curriculum that would be credit that students could take for credit, So we got the buy-in from the school to do this, but the storytelling initiative is for them to talk about their life trajectory and their family's trajectory, and then to also talk about what it means. This whole idea of what it means to be an immigrant, right? And how that can come from a great deal of strength, and the strengths of what it means to be an immigrant. And at the same time, for them to learn how to tell the story. Because one thing is to have the experience, and the other one is to actually be able to package it in a way that's compelling. So what the idea that I have is, for those of you who have heard of StoryCorps, for example, on Friday mornings NPR, you hear StoryCorps, is how can we train people to tell their story in 10 minutes? In a way that is a strong message, where they talk about the struggle, but then also the strength and what they've learned from it, and how that informs their convictions and their goals in life. And to be able to do that, but to include the people who you said, the barbershops, to include the teachers, the Head Start workers, or other people in the community, the more that we can have these conversations together, the better.
And this, I'm going to chime in quickly. And this is where, with us, we always say you have to meet people where they are. And you have to make sure your interventions are incorporating the lived experience of individuals. So you have groups like A Mother's Sanctuary. One of the other stories, Women in our piece, Kay, who has the Shades of Blue project, they meet women where they are. So it's not your traditional locations, but it's doing storytelling, it's providing that impromptu mental health screenings, and providing access to products that women may need. So you have a lot of these small grassroots organizations, and in our paper, one of our recommendations is to support those grassroots organizations, support through funding, through volunteering, because they're there, they exist, they just don't get this national spotlight, but they are there.
Great, thank you so much. I'd love to keep you even longer. As it is, we've run quite a bit over, and thank you so much to the panel. You guys were wonderful. Thank you, the audience.